So, before we start the topic rheumatic heart disease, there was an interesting case. Patient is an ANM in a primary health center in Chatra district, and frequently she complained of hemoptysis. So, blood, cough with blood, hemoptysis, and they visit different types of doctors, and they diagnose it as a tuberculosis in the case. So, she came with me, and I asked him to do chest X-ray and different types of tests like CRP, ASO titer, complete blood count. So we have seen that ASO titer is very much increased, and patient gave the history of multiple joint pain. At first, it start with the knee, ankle joint, then knee joint, and the big joints also. But it is splitting in nature. So migratory arthritis was present. So I asked her that you must do the 2D echoes. And after that, surprisingly, there is no case of pulmonary tuberculosis. It is a clear case of mitral stenosis. So patient gave the history of rheumatic fever, joint pain, rheumatic arthritis with complication hemoptysis. So that is a very interesting case. So on that background, we start the rheumatic fever. Okay. Now, rheumatic fever is a consequence of pharyngeal infection with the group A beta hemolytic streptococcus. Now, it is immune-mediated type 2 hypersensitivity reaction, not directly affected by the bacteria. Now, there is criteria. Now, John's criteria for the diagnosis of rheumatic fever. In 1992, John's given the criteria. So, the John's criteria, there are several modifications. So, there is major criteria and minor criteria. In the major criteria is carditis. Carditis occurs in about 90% patients, and it is pancarditis, mitral valve most commonly involved, and MR involved, and mitral stenosis is most common disease. There is Carey-Coombs murmur, may be heard due to MR soft, low pitched, and diastolic murmur. So, carditis is the most common major criteria of rheumatic fever in children. But in adult with rheumatic fever, it is arthritis. You must remember, in children, it is major criteria is carditis, and but in adult, it is arthritis. So, there is polyarthritis. Polyarthritis means migratory polyarthritis. No residual joint damage was occurred, dramatic response to salicylate. Chorea, St. Vitus dance. St. Vitus dance, previously I talked about St. Vitus dance. Estrogen or pregnancy can cause recurrence. It may occur in isolated condition. Erythema marginatum. In that case, face is spared. And subcutaneous nodule, non-tender along extensor surface associated with carditis. So it is what is the criteria of the subcutaneous nodule? It is non-tender and along the extensor surface of the body, often associated with carditis. So these are the major criteria. One is carditis, second polyarthritis, erythema marginatum, and subcutaneous nodule. There may be chorea. So these are the major criteria. Now minor criteria. In minor criteria, clinically we see the fever, arthralgia, previous rheumatic fever or heart disease, and in lab test we see the raised ESR, CRP, or WBC count increase. There may be prolonged PR interval in ECG recording. So, American Heart Association, they revised the Jones criteria. They include echocardiogram for the diagnosis of subclinical carditis. This is important. That in 2015, American Heart Association revised Jones criteria by including echocardiography for diagnosis of subclinical carditis. In case of rheumatic mitral valve prolapse, it may be noted that only the leaflet tip will bend into the left atrium. unlike the body of the valve leaflet is classical in mitral valve collapse. So this is the differentiating point between these two conditions. One is this rheumatic mitral stenosis and mitral valve collapse disease. So one is that only the leaflet tip will bend into the left atrium. But in case of mitral valve collapse, the body of the valve leaflet is classical in this case. Another important highlight is inclusion of monoarthritis and polyarthralgia. Monoarthritis and polyarthralgia. It is also included in this criteria. So, revised on criteria क्या बोलते हैं कि for a patient population with evidence of previous Group A Streptococcal infection, the diagnosis is initial acute rheumatic fever, 2 major manifestations or 1 major plus 2 minor manifestation. Number 1. Recurrent acute fever के लिए क्या करेंगे? 2 major or 1 major and 2 minor or 3 minor criteria. Minor criteria, low risk population में moderate and high risk population में क्या होगा? Different types of all these things. Clinical, subclinical, carditis होगा, polyarthritis होगा, chorea होगा, erythema marginatum, subcutaneous nodule. ठीक है? So ये सारी चीज हम लोग देखेंगे. लेकिन इसमें वही है कि two major type manifestations or 1 major, 2 minor. If there is initial first patient comes with your rheumatic heart disease, but if there is a recurrent ARF, patient पहले भी हुआ था, फिर भी बाद में आया, फिर दोबारा आया, तो 2 major or 1 major and 2 minor or 3 minor also included in this criteria. So these are revised zone criteria. Okay.
One question is like every year it comes, इधर उधर से घुमा के क्वेश्चन आता ही है.
So this is important because previously the initial Jones criteria and there is some difference in the revised Jones criteria. So there is inclusion of echocardiogram in the diagnosis and inclusion of monoarthritis and polyarthralgia as potential major criteria. दो चीज इसमें इंक्लूड किया मेजर में. ठीक है. So now come to the different diseases which occurs in. So rheumatic fever, इसके लिए हम लोग कुछ करना नहीं है. हम लोग कैसे प्रिवेंट करेंगे उसको ये जानना है. तो पेशेंट को टिपिकल हिस्ट्री रहेगा, माइग्रेटरी जॉइंट पेन, उसमें हम लोग उसको सब कुछ लैब इन्वेस्टिगेशन कराएंगे, सब कुछ आएगा पॉजिटिव, तो फिर हम लोग उसको ट्रीटमेंट करेंगे. सो प्रिवेंशन कैसे करेंगे? एंटीबायोटिक थेरापी हम लोग देंगे. अगर फेरिंजाइटिस केस आएगा तो उसको प्रिवेंट के लिए हम लोग फेरिंजाइटिस के लिए एंटीबायोटिक 9 दिन के अंदर दे देंगे. इसमें ड्रग ऑफ चॉइस है इंट्रामस्कुलर इंजेक्शन, बेंजाथिन, पेनिसिलिन. अगर वो सेंसिटिव है तो एरिथ्रोमाइसिन और ड्रग ऑफ चॉइस पेनिसिलिन इफ एलर्जिक टू पेशेंट. और सप्रेशन में हम लोग देंगे 12 वीक्स का एस्पिरिन देंगे. यूज्ड अगर स्टेरॉइड देंगे अगर ज्यादा उसका डिफरेंस डिफिकल्टी होगा तो. और सेकेंडरी प्रिवेंशन बहुत इंपॉर्टेंट है, उसमें हम लोग करेंगे सिंगल इंट्रामस्कुलर इंजेक्शन ऑफ बेंजाथिन पेनिसिलिन 1.2 मिलियन यूनिट वंस एवरी 3 वीक्स. 3 हफ्ता अंतर अंतर हम लोग एक बेंजाथिन पेनिसिलिन इंजेक्शन देंगे आफ्टर सेंसिटिविटी टेस्ट. नाउ patient without proven carditis should receive prophylaxis for 5 years after last episode. मतलब जब हम पेशेंट को देंगे, डायग्नोसिस होगा, तो अगर उसको उस बीच में नहीं कुछ सिम्टम आता है तो हम लोग 5 साल के लिए उसको देंगे. और until the age of 18 years, 18 साल तक अगर होगा, which is very longer, हम लोग देंगे. पेशेंट विथ कार्डाइटिस जैसे MR है या हील्ड कार्डाइटिस है should receive prophylaxis for 10 years after last episode or until 25 years of age, whichever is longer. तो ये इसका prophylaxis criteria है. ठीक है. So this is the rheumatic fever in nutshell. prophylaxis हो गया, ट्रीटमेंट हो गया, डायग्नोसिस हो गया. अब उसका सिक्वली जो है so different rheumatic heart disease. So rheumatic heart disease. So we discussed rheumatic heart disease or not?